Your doctor's office just called. They want to schedule your annual checkup. You wrote it in your calendar without thinking twice. You always do. You show up, you sit in that paper gown on the table, and whatever they recommend, you agree to. But here is what I need you to hear before your next appointment. After more than 2 decades practicing internal medicine and dedicating the majority of my career to patients over 60, I can tell you something that most physicians will never say to your face. Some of the routine tests being ordered for people your age are statistically more likely to set off a chain of harm than they are to protect you from one. That is not a fringe opinion. That is what the research shows. And it is what I have watched play out over and over again in real patients with real lives. My name is DR.Michonne. I have spent my entire professional life helping adults over 60 make smarter, more informed decisions about their own medical care. Not decisions driven by fear, not decisions driven by habit, decisions driven by actual evidence. And today, I am going to walk you through 4 routine medical checkups that I personally would not get after the age of 65. Not because I have lost faith in medicine, quite the opposite, but because knowing when not to act is one of the most powerful and most overlooked skills in all of clinical practice. Before I name the first one, I need to give you a concept. This concept will change the way you sit in a doctor's office forever. It will change every medical conversation you have from this moment forward. The concept is called the cascade effect. Picture it this way. You go in for a routine test. Everything feels fine. No pain, no symptoms, no warning signs. But the test comes back with a flag. Something looks slightly off. Your doctor, doing exactly what they were trained to do, orders a second test to investigate further. That second test finds something slightly different from the first. Now a specialist is involved. The specialist wants a closer look. A minor procedure is recommended just to clarify the picture. During that procedure, a small complication arises. The complication requires its own treatment. The treatment introduces a new medication. The medication creates a side effect. And 6 months after walking into a clinic feeling completely well, the same person is managing 3 new diagnoses, seeing 4 different doctors, and functioning at a lower level than they were before any of this started. I have sat with patients on the other side of that sequence more times than I care to count, and almost every single time the person says the same thing. I had no idea it would go this far. The cascade is not the result of bad medicine or careless doctors. It is the natural output of a system that was built to respond to findings. Once something is found, the machinery of modern medicine activates, and that machinery does not always have a gentle setting. The critical insight here, and this is what almost never gets discussed in the exam room, is that not every finding in an older body requires a response. Some findings are incidental. Some are age-related structural changes that have been present for decades without causing a single symptom. Some would never have affected the person's life at all if they had remained undiscovered. But once they are discovered, you cannot undiscover them. Now add another layer to this. The majority of major medical guidelines were designed and validated using research conducted on younger, healthier study populations. Those guidelines were then applied upward to older adults, often without the specific clinical trials needed to confirm they translate correctly. A test that has a genuinely favorable risk-to-benefit profile at age 50 may have a completely inverted one at age 75, and that recalculation almost never happens out loud in the appointment with you. Let me tell you about a woman I will call Rosalie. Rosalie was 71 years old when she came in for her annual wellness visit. Retired, active, growing her own vegetables, taking care of her grandchildren 2 days a week. She was, by every measure, doing beautifully. Her physician, following standard protocol, ordered a comprehensive panel of routine screenings. One of those screenings, which I will name shortly, returned with an irregular finding. What followed over the next 8 months was a cascade that no one designed and no one intended. 4 imaging tests, 2 specialist consultations, 1 procedure to get a definitive answer. That procedure triggered a bleed that required monitoring. The monitoring required medication. One of those medications caused severe dizziness. And Rosalie, who had been climbing stairs and chasing grandchildren without a second thought, lost her balance getting out of bed one morning and fractured her wrist. She healed from the wrist, but her confidence in her own body never fully recovered. She became cautious where she had been fearless. The original finding from that very first test? Ultimately classified as clinically insignificant. It was never going to harm her. It was never going to do anything. But the process of investigating it changed her life. I am going to come back to Rosalie before this video ends, because the question she asked me, softly, almost to herself, during one of our follow-up appointments, is one I believe every person over 65 in this country deserves to ask their doctor before agreeing to any screening test. Routine whole-body CT scanning. There is an entire industry built around full-body CT scanning for health-conscious adults. Walk into one of these clinics, lie inside a machine for 20 minutes, and walk out with a comprehensive image of everything from your neck to your pelvis. The marketing language is compelling. Complete visibility, peace of mind, finding problems before they find you. Here is what that marketing does not tell you. When you put a 65-year-old or 70-year-old body through a whole-body CT scanner, you will find something. Not occasionally, almost always. Not because something is wrong, but because a body that has lived for 7 decades accumulates incidental structural changes the way a house accumulates wear. There will very likely be a small nodule somewhere in the lung. It has probably been there since middle age. It is not growing. It is not causing any symptoms. It would never have caused any trouble. A small cyst on the liver or one of the kidneys, completely benign. A variation in spinal structure that is simply age-related narrowing, not an acute injury, not a progressive disease. Medicine has a specific name for these kinds of findings. They are called incidentalomas, discovered incidentally, not symptomatic, not necessarily meaningful. But once documented in a medical record, they require a clinical response. So the follow-up begins. A lung nodule means repeat CT imaging every 6 months for up to 2 years per standard protocol. That is a substantial accumulation of radiation delivered to a body where the cellular repair mechanisms are already working more slowly than they did decades earlier. In younger adults, the DNA repair process following radiation exposure is efficient and rapid. In older adults, those repair pathways have slowed, and repeated exposure compounds the cumulative effect. If any of those follow-up scans look even slightly different from the previous one, which happens frequently because no 2 scans are read in exactly identical conditions, a biopsy may be recommended. Lung biopsies in older adults carry a genuine risk of bleeding at the puncture site and a risk of lung collapse. Research published in JAMA Internal Medicine documented that whole-body CT scanning led to additional diagnostic procedures in more than a third of participants. And in the overwhelming majority of those cases, the findings being investigated turned out to be clinically unimportant. The procedures caused real harm. The findings that prompted them caused none. There is also the radiation consideration on its own terms. A single whole-body CT scan delivers radiation equivalent to roughly 3 years of natural background exposure. For someone who receives one annually, the dose accumulates significantly. For an older body with slower cellular repair, that is not a trivial exposure. The question to carry into any conversation about CT scanning is this: do I have a specific symptom or clinical indicator that this scan is designed to evaluate? If the honest answer is no, that conversation deserves to go much further before you agree to anything. Routine bone density scanning after age 80. I want to be clear about something before I explain this one. DEXA scanning for bone density is a genuinely valuable tool at the right age. For women in their late 50s and into their mid-60s, identifying low bone density early creates a real clinical window. There are meaningful interventions available: medication, nutrition, strength training, supplementation, that over the following decade can meaningfully reduce the risk of fracture. The time horizon is long enough for those interventions to accumulate benefit. But here is where the calculation changes, and it changes sharply. When a routine DEXA scan is ordered for an 82 or 85-year-old patient and returns an osteoporosis finding, the standard clinical pathway leads to prescription of bisphosphonate medications, alendronate, zoledronic acid. These drugs are effective at one specific thing. They change the bone density number on the next DEXA scan. They make the measurement look better. Whether they actually reduce the risk of fracture in very elderly patients is a much more complicated question than most prescribers acknowledge. Research published in both the British Medical Journal and the New England Journal of Medicine has raised serious concerns about bisphosphonate use in very elderly patients that extend well beyond the number on the scan. The first concern is atypical femoral fracture. With extended bisphosphonate use, the structural quality of bone in the thigh can paradoxically deteriorate in a specific way that makes it vulnerable to fractures occurring with minimal force, sometimes simply from standing. These fractures are difficult to diagnose, difficult to predict, and extremely challenging to repair surgically in elderly patients. The second concern is osteonecrosis of the jaw. This is a condition in which bone tissue in the jaw begins to die, most commonly triggered in older patients who take bisphosphonates and then undergo dental procedures. The result can be severe, painful, and very difficult to treat. And here is the wider clinical truth I want you to carry with you. In an 80-year-old patient, the most evidence-based approach to preventing hip fracture, which is the actual clinical goal, is not treating a scan reading with a medication. It is directly assessing and reducing the risk of falling in the first place. Fall prevention programs with supervised balance and strength training have strong clinical evidence for reducing actual fractures in older adults. Home safety reviews. Medication audits to identify drugs causing dizziness or impairing balance. Vision and hearing checks. These are interventions that target the real mechanism by which fractures actually occur. A DEXA scan that leads to a prescription without a detailed fall risk conversation is treating the number instead of the problem. If DEXA scanning is recommended after age 80, ask this question directly. Will the result of this scan change the recommended plan in any meaningful way beyond what a fall prevention assessment would already recommend for me? If the honest answer is no, then what exactly is the scan for? Carotid artery ultrasound in the absence of symptoms. The carotid arteries run along both sides of the neck and carry blood upward to the brain. Over time, fatty deposits called plaque can accumulate along the inner walls of those arteries, narrowing the channel and creating the theoretical risk that a piece of plaque could break loose, travel to the brain, and cause a stroke. Screening those arteries with ultrasound sounds, on its surface, like exactly the kind of forward-thinking prevention that modern medicine should be doing. See the problem before it causes a stroke. Fix it. Done. That logic is appealing, and in specific circumstances, it is correct. But the leap from appealing logic to actual clinical benefit requires stopping at the evidence. And when you stop at the evidence for asymptomatic patients, people who have never had a stroke, never had a mini-stroke, never experienced any neurological symptoms, the picture becomes far more complicated. The treatment for significant carotid artery narrowing is a surgical procedure called carotid endarterectomy. A surgeon opens the artery, removes the plaque buildup, and restores a wider channel for blood flow. When this procedure is performed on patients who have already experienced symptoms, a transient ischemic attack or a prior stroke, the clinical benefit is clear and well supported. In that context, operating on a narrowed artery reduces the risk of a future event. In asymptomatic patients, the mathematics change fundamentally. Multiple large clinical trials, including the asymptomatic carotid surgery trial and additional confirmatory studies, found that in patients over 70 with no stroke symptoms, the risk of having a stroke during or immediately after the carotid surgery was equivalent to, and in some analyses exceeded, the stroke risk of simply doing nothing surgical and instead optimizing the patient's blood pressure and cholesterol medications. Let me say that again with full weight. The operation carried roughly the same risk of causing a stroke as not operating at all. In that scenario, what exactly has been gained? The answer in the evidence is very little, possibly nothing. And yet, routine carotid ultrasound continues to be ordered regularly for older adults with no symptoms, setting in motion exactly the cascade I described earlier. The American Heart Association has explicitly stated in its published guidelines that routine carotid artery screening in individuals without stroke symptoms is not a recommended practice. That guidance exists in writing. The screening continues to happen anyway. If a carotid ultrasound is recommended and you have no history of stroke, no TIA symptoms, no sudden vision changes, no unexplained episodes of facial drooping or arm weakness, ask your doctor directly. If this scan shows narrowing, what is the comparative stroke risk of surgery versus optimizing my cardiovascular medications alone? I would like both numbers before I decide anything. Both numbers. You are entitled to both. Any physician who cannot provide them or who redirects you away from that comparison is not giving you what you need to make a genuinely informed decision. Aggressive cardiac catheterization, following a positive stress test, without cardiac symptoms. I saved this one for last because I believe it carries the most serious potential for harm in the specific population I am talking to today, and because the evidence behind it is among the most important and least discussed in all of cardiovascular medicine. Here is how this typically unfolds. A patient over 65 comes in for an annual checkup. No chest pain, no shortness of breath with exertion, no palpitations, no episodes of fainting or near fainting, no symptoms of any kind related to the heart. But a stress test is ordered as a routine preventive measure. The stress test returns abnormal. Perhaps the electrical tracing of the heart showed changes during the exercise portion. Perhaps the imaging component flagged reduced blood flow to part of the heart muscle. The cardiologist reviews the result and recommends cardiac catheterization. Catheterization involves threading a thin, flexible tube through an artery, typically in the wrist or the groin, advancing it upward into the coronary arteries of the heart, and injecting contrast dye to directly visualize the vessels. It provides a clear picture of where blockages exist and to what degree. It is also an invasive procedure with a real risk profile for older patients. The risks include bleeding at the arterial insertion site, which in older patients on blood thinners can be difficult to control. Arterial damage at the entry point, contrast dye nephropathy, kidney injury caused by the imaging dye, which is a particularly serious concern in older patients whose kidney function has already declined with age, and a small but genuine risk of stroke during the procedure itself, caused by tiny air bubbles or fragments of plaque dislodged as the catheter moves through the arterial system. Now here is the finding from the medical literature that I need you to hold on to. The COURAGE trial, the ischemia trial. 2 landmark studies, both published in the New England Journal of Medicine, both rigorously designed, both examining the exact clinical scenario I just described. Patients with stable coronary artery disease and no significant symptoms. Both trials found, with consistency and statistical power, that for patients in this category, aggressive intervention through catheterization followed by stenting or bypass surgery did not reduce the rate of heart attack or death compared to optimal medical therapy managed with medications alone. Read that once more. The invasive approach, with all of its procedural risks, produced the same cardiac outcomes as a carefully managed medication regimen. Not better outcomes, the same. This means that for an older adult with no cardiac symptoms, a positive stress test that leads directly to catheterization and stenting may expose that person to the full weight of procedural risk, including stroke, kidney damage, and arterial injury, while delivering zero additional survival benefit compared to what could have been achieved with the right prescriptions. There is a further complication worth naming. Stress tests carry a higher false positive rate in older adults than in younger populations. In women over 65 specifically, the false positive rate is notably elevated. A positive stress test in a symptom-free older woman is not the same clinical signal as a positive test in a 45-year-old man with chest pain during exertion. The pretest probability is different, the meaning is different, and the appropriate response should be different. But in practice, a positive result feeds into the same referral chain regardless of symptom status or age-specific context. Before agreeing to cardiac catheterization after a positive stress test, sit with your cardiologist and ask this clearly. I do not currently have cardiac symptoms. Based on the COURAGE and ischemia trial findings, what does the evidence show about outcomes for patients like me who pursue catheterization versus those who are managed with medication? Walk me through both paths. If that conversation happens thoughtfully, you will be in a far better position to make a decision that is right for your specific body, your specific risk profile, and your specific values about what matters most at this stage of your life. I want to come back to Rosalie now. After her wrist healed, during one of our quieter conversations in my office, she turned to me and asked something that I have thought about almost every day since. She said, "Dr. Michonne, if I could go back to before that first test and I was only allowed to ask one question, what would that question be?" I told her without hesitation, "The question is this: if this test finds something, what exactly would we do about it? And is that course of action appropriate and worth the risks for someone my age, in my current state of health?" That single question, asked before agreeing to any screening, forces the clinical conversation to move forward in time. It requires your doctor to think through the cascade before it starts, rather than after it has already been set in motion. It makes you the center of the decision, rather than a passive recipient of standard protocol. It is the question the system is not designed to ask on your behalf, so you must ask it yourself. Rosalie told me she was going to write it on a card and keep it in her wallet. She said she was going to give a copy to every friend she had over 65. Consider this video my way of doing the same thing for you. If you have made it this far, you are someone who takes your health seriously. You want real information, not reassurance. But most people who watch a video like this click away without subscribing, and then the algorithm never shows them this channel again. If this conversation has changed how you think about even one aspect of your medical care, subscribe right now. It takes a single tap, and the content ahead on this channel, on aging, on medications, on how to advocate for yourself in a system that moves fast and assumes compliance, is content you genuinely do not want to miss. Let me bring all 4 of these together with complete clarity before I let you go. Checkup number 1. Routine whole-body CT scanning. These scans will almost always find something in a body over 65. Not because something is wrong, but because age-related structural variation is normal and universal. The findings they produce, incidentalomas, trigger clinical cascades of follow-up testing and procedures for things that were never going to cause harm. Meanwhile, repeated CT scanning delivers accumulating radiation to a body whose DNA repair mechanisms grow slower with every passing year. Checkup number 2. Routine bone density scanning after 80. Finding osteoporosis in a very elderly patient typically leads to bisphosphonate medications that carry serious risks of their own, including atypical femoral fractures and jawbone complications, while fall prevention programs, which actually address the real mechanism of fracture, have stronger evidence and fewer dangers. After 80, treating the scan number may be far less effective than treating the fall risk directly. Checkup number 3. Carotid artery ultrasound without symptoms. The surgery used to treat significant findings from this scan carries a stroke risk that in asymptomatic patients over 70 is equal to or greater than the stroke risk of non-surgical management with optimized medications. The American Heart Association does not recommend this as routine screening, and yet it continues to be ordered, and the cascade it initiates continues to affect people who walked in with no symptoms at all. Checkup number 4. Aggressive cardiac catheterization following a positive stress test in the absence of cardiac symptoms. Landmark clinical trials have established clearly that stable coronary artery disease without symptoms produces the same outcomes whether managed with procedures or with medications alone. The procedures carry real risks. The additional protective benefit does not materialize. A positive stress test in an asymptomatic older adult is not an automatic mandate for invasive investigation. None of what I have said today means stop going to your doctor. Preventive medicine saves lives. Blood pressure monitoring, blood sugar management, immunizations, hearing and vision screenings, annual reviews of your full medication list, regular conversations about mental health and cognitive function. These interactions are genuinely valuable, and I encourage every single one of them. What I am asking you to do differently is walk into those appointments prepared. Carry a question. Write it on your phone if you need to. Print it out, whatever it takes. If this test finds something, what will we do about it? And is that the right course of action for someone my age and in my current state of health? Ask it every time, without exception, for every screening placed in front of you. If your doctor gives you a clear, specific, age-appropriate answer, proceed with confidence. If the answer is vague or dismissive, or does not actually engage with what you asked, That itself tells you something important about whether you have all the information you need. Which of these 4 surprised you the most? Tell me in the comments. I read every single one, and I respond to as many as I possibly can. And if you have lived through a medical cascade yourself, where one routine test led somewhere you never anticipated, please share that experience below. Your story is not just your own. It is information that could help someone sitting in a waiting room tomorrow, staring at a consent form, wondering whether to ask a question they do not quite have the words for yet. Share this video with someone you love who is over 65 and who goes to every scheduled appointment without ever questioning a single recommendation. The most powerful thing you can do for their health today may not be a supplement or a diet change. It may simply be giving them this one question. Subscribe for more honest medical conversations that give you the full picture, not the comfortable picture, not the convenient one, the one that actually serves you. I am Dr. Michonne, and you always deserve the truth.